Hello everyone, it's Dr. Locklear here, and I'm coming to you with Exemplar 18.B, which is diseases of the eye, and that falls under our concept of sensory perception. So we are going to be looking at, several things: cataracts, glaucoma, and macular degeneration, all which are very detrimental to vision and can cause you to lose your eyesight and go blind. So let's look at our outcomes. We're going to look at the pathophysiology of the most common diseases. So we're going to look at how these diseases occur. What are the causes of these diseases? What are the risk factors and what are preventive measures? What are the clinical manifestations that we see? So when we get down to the nursing process, what do we see when we do a physical assessment on the patient? We're going to look at the diagnostic testing that is used for these three particular disease disorders. We're going to look at considerations of care with patients that have these eye disorders across the lifespan. These are not just disorders of older adults. They do happen at different ages, but you do see most of these three, cataracts, glaucoma, and macular degeneration, usually in adults. So let's get started. I thought you guys would really like this. You have tiny websites burned onto your retinas, and as much as reading as you all do and studying and being on a computer, you probably feel this way. I know I do sometimes. So what is our overview? So what are the most common diseases of the eye? There are many diseases that affect the eyes. The most common are cataracts, glaucoma, and macular degeneration, and all three are different. The other one is inflammation of the eye, and we will look at some of those as well. A cataract is an opacification or a clouding of the lens of the eye. It can significantly interfere with light transmission to the retina, so everything looks a little blurry, and the ability to perceive images clearly. And with cataracts, you can't see well at night to drive, or with glaucoma or macular degeneration. At nighttime with cataracts, the street lights and car lights look very bright, and they look like what they call starburst. And so you may hear a patient explain it that way. Glaucoma is characterized by optic neuropathy with gradual loss of peripheral vision and usually increased intraocular pressure, force within the eye causing tissue damage. So with glaucoma, we're going to see how the person starts to have what we call tunnel vision, and we'll talk about that. Age-related macular degeneration is the gradual process of the degeneration of the macula in the back of the retina. And that's that little spot that you see when the doctor does the eye exam. Inflammation of the eye can occur because of local or systemic allergic reactions, conjunctivitis, uveitis, eye injury, glaucoma, macular edema, or dry eye syndrome. Dry eye syndrome is a condition in which the eyes do not produce enough tears or make the right type of tears for the eyes to stay healthy and comfortable, because the eye is not made to be dry. It needs to be lubricated and saturated, and if we don't have the right tear production, you can have a lot of issues with dry eye. So let's look at the pathophysiology of cataracts. Nurses should recognize that not all cataracts need to be removed in early stages, but many patients will eventually have them surgically corrected. So you go in for an eye exam and the doctor says, you've got age-related cataracts, but if it's not causing you any problem, then they do not recommend that you have them removed in the early stages. So what is the patho and the cause? Most cataracts form as a result of the aging process and are known as age-related cataracts. As the lens ages, its fibers and proteins change and degenerate. The proteins clump, clouding the lens and reducing light transmission to the retina. This process generally begins at the periphery of the lens. It gradually spreads to involve the central portion. The entire lens may eventually become opaque. The lens may also discolor over time, affecting the ability to accurately discriminate colors. And you can see in the picture here that the opacity in this eye, that is a cataract, and it covers that lens and you can't see. In addition to age-related cataracts, other types are secondary cataracts. They can form after surgery is performed to treat another eye disorder such as glaucoma or as an effect of medication or another primary disorder. Patients who require regular or recurring doses of corticosteroids, for example, are at risk for secondary cataracts. Traumatic cataracts result from an injury to the eye. Radiation results from long-term exposure to ultraviolet light or radiation treatment. Congenital cataracts appear at childbirth, and pediatric cataracts can form in childhood. And here you see some of, again, the causes, and we're going to look at those when we get to the etiology part. Aging, diabetes, because diabetes affects our circulation. Alcohol affects our circulation, and it causes high blood pressure, which causes more pressure in the eye. Exposure to radiation, ultraviolet lights, hereditary, and being overweight because of the fat deposits. So what are the risk factors? As age is the greatest single risk factor for cataracts, genetics may contribute to the risk, although the link is unclear. Environmental and lifestyle factors are also an issue. Long-term exposure to sunlight, or those UV rays, increases the risk for cataracts. Cigarette smoking, heavy alcohol consumption, eye trauma, diabetes, and again, diabetes affects the circulation. Certain drugs such as corticosteroids, lovastatin, which is a statin drug for cholesterol, phenytoin or Dilantin, which is a seizure medication, thorazine, and Myloran. And all of these can cause that opacity to occur. Although there are no known methods to prevent cataracts, patients can reduce their risk by not smoking, refraining from heavy alcohol, and protecting your eyes when outside, wearing those protective type of shades. Maintaining a healthy weight and managing other health problems, like keeping your blood pressure under control and managing your weight to keep your cholesterol levels down. A diet that includes adequate consumption or supplemental vitamins C and E, as well as lutein and zeaxanthin, may reduce the risk of developing cataracts or slow their progression. And I know, and I've shared my story a little bit with you guys, I had cataract surgery this summer, which was causing some glaucoma issues, so I kind of was dealing with both, and it was a surprise because at first it was age-related cataracts, and then I ended up having some glaucoma issues because of it. And so one of the vitamins that I have to take is vitamin A to help my eyes. I actually take what's called A-REDs, and your eye doctor will recommend those. So what are some preventions? Again, not smoking, reducing alcohol consumption, maintaining a proper diet, control your diabetes. And here is a website that when you click on it, it takes you to diseases of the eye, and it'll take you straight to the website that talks about cataracts through the NIH, which is the National Institute of Health. I thought that would just be good information for you. So glaucoma, in the picture, you start to lose, you see that the one on the left is normal vision, but the one on the right, you start to get down to that central vision, and you can only see like a circle when you're focusing. Glaucoma is a silent thief of vision. The patient typically experiences no manifestations other than narrowing of the visual field, which occurs so gradually that it often goes unnoticed until late in the disease process. And you have two different types. You have open angle and angle closure. Primary glaucoma, which has no identified cause, has two major forms in adults: open angle glaucoma and angle closure glaucoma. Open angle is the more common. Both terms refer to the angle formed at the point where the iris meets the cornea of the eye's anterior chamber. And if you'll look on the next page, you can see an example where it shows that little corner where is starting to close. So figure A is open angle and figure B is acute angle. And I had open angle glaucoma, and it was starting to narrow, and my eye didn't want to drain. But fortunately, my pressures were good at that time. In open angle, the anterior chamber angle between the iris and the cornea is normal, thus the term open angle. However, the flow of aqueous humor through the trabecular meshwork and into the canal of Schlemm is relatively obstructed. The cause of the obstruction is unknown. And they told me, like for mine, it was because my cataract was getting bigger. The trabecular meshwork increasingly inhibits the outflow of aqueous humor, which is the liquid in your eye, and the intraocular pressure gradually increases. The results are neuronal ischemia and optic nerve degeneration or damage, which leads to gradual loss of vision. Open angle tends to be a chronic and gradually progressive disease. It affects both eyes, although the pressures and progression may not be symmetric. Open angle is the most common form in adults. And then you have the angle closure glaucoma, which is also called closed angle or narrow angle. You have a narrowing of the anterior chamber angle occurs because of corneal flattening or bulging of the iris into the anterior chamber. So if it flattens, it'll bulge into that chamber. When the lens thickens during accommodation or the iris thickens during pupil dilation, this angle can close completely. Closure of the angle blocks the outflow of aqueous humor through the trabecular meshwork and canal of Schlemm, and the intraocular pressure rises abruptly. This increase in IOP damages the neurons of the retina and the optic nerve, leading to a rapid and permanent loss of vision if not treated promptly. Patients may have intermittent episodes lasting several hours before they have a more typical prolonged attack of angle closure glaucoma. And so this is the worst of the two. So if you gotta have it, you want to have you want to have the open angle, not the closed angle. Because of the effect of pupil dilation on aqueous outflow in angle closure glaucoma or closed, episodes often occur in association with darkness, emotional upset, or other factors that cause the pupil to dilate. Patients with a history of the condition must avoid medications such as atropine and other anticholinergics that can cause mydriasis or dilation of the pupil. Angle closure glaucoma is typically unilateral and occurs between 1 and 40 times in every 1,000 Americans. The cause of glaucoma is unknown. It is thought to have a hereditary component, but no hereditary pattern has been identified. Cardiovascular disease or diabetes may contribute to it as well. So what are some of the risk factors? Glaucoma is the second leading cause of blindness worldwide. Age and race are primary risk factors for the disease. Patients with an immediate family member with glaucoma have a 4 to 9 times higher chance of developing the disease. Long-term steroid use is also a contributing factor. So you may see this more prominent in people who have COPD and respiratory disorders that are constantly on prednisone and those type of steroid drugs. Prior eye surgeries, especially blunt trauma or penetrating injuries, may cause secondary glaucoma called secondary open angle glaucoma down the road. Other risk factors, Asian descent, and these seem to be at more risk for angle closure glaucoma, while those of Japanese are at risk for normal pressure glaucoma, in which the optic nerve is damaged despite a low intraocular pressure. Other factors are myopia, hypertension, thin corneas, and diabetes. So you need to go get regular comprehensive eye exams. Exercise helps to lower intraocular pressure. The benefit only occurs as long as exercise is done regularly. Individual needs to place the head lower than the heart, such as certain poses in yogurt. This can increase intraocular pressure. So let me make sure I say that correctly. Exercises that require the individual to place the head lower than the heart, such as certain yoga poses, can increase IOP. So this is a negative effect from the exercise. Other methods to prevent the development of glaucoma include eating a healthy diet, keep those cholesterol levels low, and that's more cataracts, but we all need a healthy diet. Maintaining a healthy weight, preventing overexposure to sunlight, and refraining from smoking. And again, here's the National Institute of Health website for glaucoma as well. What are preventive measures? Again, regular exams, exercise as long as it doesn't cause increase in pressure, prevent overexposure to sunlight, and stop smoking, maintain a healthy weight and diet. Macular degeneration, and you see this is what they'll show you when you go get your, that's your optic disc right there, and that's what's damaged when you have MGD. I'm sorry, yes, macular degeneration. I'm sorry, I got fumbled up on my words there. But anyway, that optic disc right there is damaged. So what happens? The leading cause of legal blindness and impaired vision in people over the age of 60 is AMD, a gradual process of degeneration in the macula of the retina. Among individuals aged 75 and older, nearly 1/3 are affected by this type of macular degeneration. Non-exudative or dry macular degeneration is the more common form of AMD. And so you will see, and AMD again being age-related macular degeneration. So you will see there's not a fluid issue, okay? Non-exudative macular degeneration begins with the accumulation of deposits called drusen beneath the pigment epithelium of the retina. Over time, these deposits enlarge and increase in number. The pigment epithelium detaches in small areas and becomes atrophic, interfering with sensory function of the macula. Vision loss is typically not significant and the disorder progresses slowly. There is a risk that the disorder will progress to an exudative state of the disease. So when you get to the exudative state, you're going to see a different type of situation here. So with the exudative, or what we call wet, is exudative macular degeneration or wet macular degeneration, causes growth of abnormal blood vessels in the potential space between the choroid, which is the vascular layer of the eye, and the retina, which is your neurosensory layer. These new vessels are prone to leak, elevating the retina from the choroid and distorting the vision. Although exudative macular degeneration is typically a gradual process, bleeding can lead to acute vision loss in some cases. With significant or repeated bleeding episodes, scar tissue forms and central vision is permanently lost, and it can't be repaired. This form accounts for about 10% of all the cases, so this wet form. Globally, macular degeneration is a major cause of blindness. For Americans who are over 65 years of age and older, it is the primary cause of vision loss and blindness. Caucasians are more likely to develop macular degeneration than other ethnic backgrounds. So that's something we need to ask for. You know, we really need to pay close attention to people's ethnicity because certain things are more specific to their ethnic background. So what are the risk factors for macular degeneration? The most significant risk factor for developing AMD is aging. Other non-modifiable means you can't change, race, eye color, and family history, more frequently in women, likely because they tend to live longer. Modifiable risk factors include smoking, obesity, poor cardiovascular health, and excessive UV exposure. And it mentions eye color, and if I'm not mistaken, I think one of the eye colors is green eyes, which I have green eyes, and look what happened. I got it. Because smoking is a significant risk factor for developing AMD, patients can reduce their risk of developing, of course, by not smoking. They can also decrease their risk by reducing UV exposure, maintaining a low body mass index, eating a healthy diet that is high in antioxidants and healthy fats. Managing other conditions also, such as heart disease, are some of the other ones as well. So here is the National Institute of Health for Macular Degeneration website as well. So you can go to any of these websites and get all kinds of information to give your patient when you are educating them. Clinical manifestations. As a cataract interferes with light transmission through the lens, visual acuity decreases, affecting close and distance vision and causing glare. Glare affects the individual's ability to adjust between light and dark environments. Very hard to drive at night. Color fading or yellowing of colors occurs. When the cataract is mature, the pupil may appear cloudy, gray, or white rather than black. Cataracts tend to occur bilaterally unless they are related to eye trauma. Open-angle glaucoma has no symptoms in many cases, and vision will remain normal for a while. Then, as the optic nerve becomes more damaged, blank spots will start to appear in the visual fields. With advanced disease, the individual may notice reduced peripheral vision, so you can't see over to the right or left of your body. With advanced disease, again, you'll see reduced peripheral vision, and it starts to become more central vision or tunnel vision. Although angle closure glaucoma is also typically free of symptoms, it can cause intermittent pain or photophobia, which is sensitivity to light. Symptoms such as severe eye and face pain, general malaise, nausea and vomiting, seeing colored halos around lights, and experiencing an abrupt decrease in visual acuity are associated with acute episodes of angle closure glaucoma. The conjunctiva of the affected eye may be reddened, and the cornea may be clouded with corneal edema. The pupil may be fixed, non-reactive to light at midpoint. Patients with AMD will often report blurred vision, blind or blurry spots within their central vision field, and colors appearing less bright. They have difficulty adjusting when going from bright light to lower light situations. They will also report difficulty in recognizing people's faces. Straight lines may appear wavy. Because central vision fields are affected, or visual fields are affected, the individual must learn to rely on peripheral fields in order to function. So you're losing your vision, you're losing your ability to focus and see. Here's some tidbits for open angle glaucoma. Again, the increased intraocular pressure, the halos, and seeing lights around looks like halos. And then here's your angle closure glaucoma, a hazy cornea, fixed and dilated pupils. And then again, with your AMD, the blurred vision, and the colors are less bright, and you see the picture here. This is an actual picture of someone vision that has AMD. See how blurry that is? So you really become what we call legally blind. You can't drive, get a driver's license. It's very difficult to function. Some of the collaboration: the ophthalmologist, occupational therapist, social worker, anybody that works, in the visual field, and then as you lose your vision, anybody in rehab. And here's a little tidbit. What's the difference between an optometrist versus an ophthalmologist? I'll let you read that on your own. Diagnostic test. Cataracts are diagnosed on the basis of the patient's history and eye exam. The Snellen and Rosenbaum charts are used. A dilated eye exam with either an ophthalmoscope or slit lamp examination provides a magnified view of structures of the eye. Ophthalmoscope examination confirms the diagnosis by identifying the location and extent of a cataract. As the cataract matures, ophthalmoscopy reveals a dark area instead of the red reflex that you should see in the back of the eye. Although glaucoma cannot be predicted, prevented, or cured, in most cases it can be controlled, and vision can be preserved if it is diagnosed early. But remember, you can have symptoms for a long time, so the best thing to do is go get your eyes checked on a regular basis. Because the most prevalent type of glaucoma, open angle, has few symptoms, routine eye exams are recommended. Measurement of IOP, fundoscopy to assess the optic disc, and visual field testing are used. Many patients with glaucoma will not have high intraocular pressure on examination. I didn't. Even though I was having some glaucoma issues, my pressure, the highest it ever got was 18. Regular pressure readings over time and an optic nerve exam are essential parts of a comprehensive eye exam. The following diagnostic studies are performed by an ophthalmologist or other eye specialist. And so you have tonometry, and I'm not going to read these. You can read these on your own. Tonometry is indirectly measures intraocular pressure. Fundoscopy, visual inspection of the optic fundus. Gonioscopy, oscopy, it should be oscopy. Some of these words are very hard to say. Measures the depth of the anterior chamber, visual field testing, and of course we know we should have 20/20 vision. AMD is diagnosed through vision and retinal examination. The Amsler's grid, and I think I've got, yeah, here's the different types of Amsler grids that they use. I don't remember going through any of this. I don't remember that. Patients with wet AMD report the same symptoms as those with dry. So they use this Amsler grid for patients with macular degeneration. Lines that are straight may appear crooked, bent, or irregular. There may be a difference in the appearance of the size of objects. A safety alert. Visual distortions increase the risk of falls and other injuries. Of course, when your vision's not right, you're going to be at risk for falls. And so we need to be very mindful of these patients. Pharmacological therapies. Before we move on, look on page 1457, and here are clinical manifestations and therapies, and it lists congenital cataracts, age-related cataracts, open angle, closed angle, and then your macular degeneration. It gives you your clinical manifestations and your clinical therapies. And so make sure that you read over this, okay, because each one requires a different type of therapy. So what are your pharmacological agents that we use? And you have a drug list on 18.1. And so you have your alpha-2 adrenergic agonist, and these stimulate alpha-2 adrenergic receptors in the eye to dilate the pupil. You have your beta adrenergic blockers, and these block beta receptors in the anterior eye to decrease the production of aqueous humor, therefore decreasing intraocular pressure. You have carbonic anhydrase inhibitors, and they block the enzyme carbonic anhydrase, which is needed to produce aqueous humor. You have your cholinergic agonist, and they have the same effect as acetylcholine, causing the pupil to constrict or miosis. Cholinesterase inhibitors are miotics, and this inhibits the enzyme cholinesterase. It allows acetylcholine to stimulate the ciliary muscle and produce miosis, thus increasing the outflow of aqueous humor, which decreases the pressure. You have your docosinoids, and they increase the outflow of aqueous humor as well. And then you have prostaglandins and a few more listed, listed on page 1459 as well. Please read through these and read through the nursing considerations. Also in this chapter, and I may have already covered it in another chapter, I think I have, how to give the eye drops. And I think I covered that in another chapter. And you should have had that in Fundamentals of Nursing as well. So let's look at the pharmacological beyond the chart. No medications are available for treating cataracts. For glaucoma, topical medications are effective for many patients. The principal categories of medication used to treat glaucoma include alpha-2 adrenergic agonists, beta adrenergic blockers, carbonic anhydrase inhibitors, cholinergic agonists, and prostaglandin analogs. The therapy prescribed depends on several factors, including the patient's history. Alpha-2 adrenergic agonists dilate the pupil, reduce the production of aqueous humor, and increase its absorption, effectively reducing IOP in open-angle glaucoma. Bremidine may be prescribed along with a beta adrenergic blocker or when beta adrenergic blockers are contraindicated. Apraclonidine may be prescribed when other drugs do not sufficiently reduce intraocular pressure, but adverse effects make it inappropriate for long-term use. Beta adrenergic blockers reduce IOP by decreasing the production of aqueous humor in the ciliary body. Because beta adrenergic blockers do not affect pupil size and lens accommodation, they do not have adverse effects on visual acuity that adrenergic agonists do. Carbonic anhydrase inhibitors decrease production of aqueous humor and are used primarily as adjunctive therapy. Dorzolamide and brinzolamide are administered as eye drops. Acetazolamide may be given orally, IM, or IV. Prostaglandin analogs increase aqueous outflow. They are similar to beta adrenergic blockers in that their longer duration of action means that they require only a daily dose. In acute angle closure glaucoma, diuretics such as mannitol may be administered IV to achieve a rapid decrease in IOP prior to surgery. Fast-acting biotic eye drops such as acetylcholine are also administered preoperatively to constrict the pupil and draw the iris away from the angle and from the canal of Schlemm. Angiogenesis inhibitors are the primary pharmacological therapy used in the treatment of wet macular degeneration. These drugs block the production of VEGF, thus slowing the progression of the disease. Corticosteroids or non-steroidal anti-inflammatory drugs are used to treat eye inflammation and post-operative pain and inflammation after cataract surgery. I had to put eye drops in my eyes like 4 times a day for 2 weeks, and then 3 times a day, and then 2 times a day. And it was a combination of 3 different medications, and one of them was antibiotics. And I had a schedule I had to follow, and I had to do that to get the proper results from my surgery. They make it very clear to you when you have cataract surgery to put those eye drops in as prescribed. Antihistamines, corticosteroids, and mast cell stabilizers are used to treat allergic symptoms in the eye. Dry eye is treated with drugs that decrease eye inflammation or improve the film of tears across the eye. Drugs to treat eye inflammation are administered topically as ophthalmic solutions, gels or ointments, or by intraocular injections. The role of the nurse in teaching patients to recognize side effects is critical. The nurse should ensure that the patient has been instructed on and understands how to properly instill the eye drops, and that's in Exemplar 18.C, the one I talked about on eye injuries. And then it talks about surgery. Surgery can be used for treatment of cataracts, glaucoma, and wet age-related macular degeneration. Surgical removal of cataracts is the only treatment used at this time. It's performed when the cataract has developed to the point at which vision and ADLs are affected. A mature cataract also may be removed when it causes a secondary condition such as glaucomas or uveitis. So if the intraocular lens, an artificial lens to replace the diseased lens, is to be implanted during surgery, the corneal curvature will be measured, and they do all that before you go to surgery. And here is a wonderful picture of Dr. Locklear back this summer. I had one done in June, and I had one done in July. They do them about 3 weeks apart. And this was after surgery. Now, don't laugh at me because it was hot and I had no makeup. My hair was a hot mess. But you see, I had to wear the dark glasses every time I went outside. And trust me, you need the dark glasses. And I had to wear the eye patch for several nights. And I could not lay on the side of my affected eye. And they only do one eye at a time. Once they do it, your pupil will stay dilated for quite some time. And I said I looked like something out of a Walking Dead or zombie movie. You should have seen my pupil. It was so big. I wish I could have showed you a picture of that. Cataract surgery is typically done on an outpatient basis. Extracapsular extraction, in which the anterior capsule, nucleus, and cortex of the lens are removed. Using an operating microscope, the surgeon makes a small incision of the cornea and extracts the lens intact or via emulsification and aspiration. After removal of the lens, the eye can no longer focus light on the retina and vision is seriously affected. An intraocular lens is implanted at the time of surgery and restores binocular vision. And I have implants in both of my eyes. And it's a process. Don't let anyone tell you that cataract surgery is an easy thing to go through, because it is not. I really was surprised at how much recovery time is required in cataract surgery and how long I had to wear the glasses and before I could drive again. It was not an easy process to go through. Some patients who undergo extracapsular extraction may develop opacification of the remaining posterior capsule after surgery, or secondary cataract. To decrease the risk of infection and aid in healing, the physician will likely prescribe antibiotic eye drops and anti-inflammatory eye drops, such as your steroids. And it wasn't painful. I did have a little bit of eye pain the day of my surgery, and when I went back in to have my second eye done, the physician asked me, did I remember having any pain during the first eye surgery? And I told him no, but he said that I did. He said that I told them while I was under anesthesia that I was having pain. So when I had the left eye done, I remember it hurting, and it took longer for my left eye to heal than my right eye. And I still am having a little issue with my left eye to this day. It just didn't heal up as fast as the right one. But I remember having pain, and I remember seeing the laser coming at my eye out of the corner of my eye. So it's a scary surgery. It really is. Corticosteroid anti-inflammatory ophthalmic drugs may increase intraocular pressure, so they are usually given for only 2 to 3 weeks rather than 4 to 6 weeks like the NSAIDs. So what do they do for glaucoma? Surgical management of glaucoma involves improving the drainage of aqueous humor from the anterior chamber of the eye, or decreasing the aqueous humor production. Trabeculoplasty. That's a tough one. So I don't think I'm saying that right. I'd have to YouTube it to say it right. But what this does is the most common procedure. In a laser, this type of procedure, argon laser creates multiple burns spaced evenly around the trabecular meshwork. So I guess it's trabeculoplasty. I guess close enough. As they heal, tension on the resulting scars stretches and opens the meshwork. This non-invasive technique requires no incision and can be performed as an outpatient procedure, making it the treatment of choice. In a trabeculectomy, A permanent fistula is created to drain aqueous humor from the anterior chamber of the eye under the conjunctiva. A trabecular is usually performed under general anesthesia. If it's not successful, a tube or shunt may be placed. And so, anyway, they do these different procedures to relieve the pressure and correct the issue with the aqueous humor. And you can see the other ones listed here in your reading, and I'm going to let you read those on your own because this lecture is getting a little long. Okay. And then for your age-related macular degeneration, it talks about doing laser surgery. It says in laser surgery, fragile blood vessels are destroyed, preventing bleeding. And so they're trying to, prevent any damage to that optic nerve. So make sure that you read over those three. And then cataracts, it talks about non-pharmacological therapy. If a cataract does not interfere with the ability to perform ADLs or is not associated with any other eye pathology, the surgical removal is not necessary. I've known for 5 or 6 years that I had cataracts, but they decided to go ahead and do it, like I said, because it was starting to cause some open angle glaucoma, and that's a whole nother issue. For patients with glaucoma, relaxation and regular exercise may lower the pressure, and then maintaining normal blood sugar readings. Physical exercise, just taking care of your diabetes, taking care of your weight, taking care of your hypertension. It says participants in one study have been able to lower their IOP enough that they no longer needed to take their beta adrenergic blocker medications. That may not always be the case. And then when it talks here about your age-related macular degeneration, it can be slowed by using high doses of antioxidants and zinc. And then there's some research about vitamin E, copper, zinc, beta carotene. All of these are still under research. And so here's your little picture of what your normal eye looks like versus a glaucoma. And you can see the buildup of the aqueous humor in the eye. And again, with AMD, here's some things that we can do to help us that are non-pharmacological things, and helping us to have things to magnify and help us to read print better. And then for children, I'm going to let you read this on your own. Again, this is getting kind of lengthy. I'm almost at an hour. But please read through congenital cataracts and pediatric glaucoma and juvenile macular degeneration and pregnancy. And then most of what we've already been talking about has already been issues with the older adult. And it goes through here. Here's you some information on the slides that is in the reading as well. Okay, failure to notice toys or faces, lack of reaction to light. You definitely need to get their little eyes checked. And they check all that when they're born, but still, you notice things as a parent as the child is growing. Okay. It's difficult to diagnose with pediatric glaucoma. So again, if your child is squinting, bumping into things, just displaying poor vision, you need to take them in and get their eyes checked. And, once they get school age, the teacher may contact you and say, they're having trouble seeing, in class, so you may need to get them in, okay? And then here's the older adult. And then the nursing process. So we want to provide a safe environment, alert to potential for eye disease in all patients, and discuss lifestyle modifications. And we've talked a lot about that. I put these little pictures here. Protect your eyes. Some of these things that we use, we could have prevented if we just had on the proper eye gear. We need to do that. Observation and patient interview. The nurse can observe general difficulties with vision based on the patient's ability to see objects and read text. The patient interview should include assessing the effect of vision changes on lifestyle and activities, the ability to read, watch TV, participate in work, recreational activities, and so forth. That list's not conclusive. And the patient's history of smoking, diabetes, and use of prescription drugs, such as those steroid medications. The nurse may be able to observe the presence of cataracts if they are advanced enough to cloud the pupil. The patient interview should assess the patient's family history of eye disease. The nurse should be alert for signs and symptoms that indicate a patient may have new and rapid onset of macular degeneration. The patient should be referred for ophthalmologic for an eye exam. Let's say that, okay? Ophthalmologic. I'm going to get it. Early intervention may preserve a greater degree of vision and slow the progress of the disease. Now, I know you all were thinking, Dr. Locklear's been teaching 10 years and 20 years, and she don't know how to say these words yet. Well, you know what? These words haven't changed. They still spelled the same way, and I still have a hard time pronouncing them. So we'll get through it, okay? Physical exam. Physical examination for diseases of the eye should include testing the patient's distant and near vision, testing peripheral fields, and testing on an Ansel grid. And I showed you a picture of the Ansel grid, and that's for age-related macular degeneration. Examination for specific eye disorders will depend on the signs and symptoms, of course. They're going to look, when I went in, I go every year because I've had glasses all my life, and I go in every year and get my eyes checked. But I could tell, I knew something was wrong with my eyes because I was having a lot of trouble seeing to drive at night. What are our nursing diagnoses? Anxiety, fear, inadequate health management skills, inadequate health maintenance skills, and risk for injury. And so what is our planning? Remain free from injury. The patient will be able to articulate an understanding of the reasons for and risk involved. They really taught me well, and I was able to talk back to them. I'm glad I had a chance to cover this particular topic in your class because I went through it. And I wish I could get my doctor to come in and talk to you about all what they did and how they do things when it comes to cataracts and glaucoma. Implementation. So we've already talked a lot about this. Discuss possible adaptations in the home for the vision changes, removing scattered rugs, improving lighting, safe navigation, provide instructions related to unilateral vision loss, teach the patient to scan, turn the head towards the affected side. For the patient in the hospital or healthcare facility, notify housekeeping and alert all personnel not to change the arrangement of the room. That's important. Promote wellness and teach principles of self. So chronic conditions that may affect the ability to administer eye drops, you may need to teach someone else. If you've ever had to give yourself eye drops, you know it's not easy to do. I struggle with that. Usually, a lot of times I drop it on my cheek, or or my nose, and I'd have to do it all over again. So we may have to teach them, a different way to do their eye drops, or have somebody come in and help them. Facilitate orientation and environmental modifications. This will help reduce their anxiety. Call them by name. Don't ever touch a patient till you introduce yourself. You're invited in the room and you call them by name. Orient them to person, place, and time, and educate them and state the purpose of your visit. You should always do that regardless of any disease. Facilitate orientation and environmental modifications. Make sure that they've got their visual aids in. If you wear glasses, you know what I'm talking about. Make sure you put the patient's glasses on and they are cleaned. Provide or suggest other tools or items that can help compensate for diminished vision. Your hearing gets sharper when you can't see as well. Help them with their meals, help them with their ADLs. And promote psychosocial well-being, because I can tell you right now, people that lose their vision, they become depressed very quickly because they lose their independence, and people don't want to lose their independence, and we have to help them with coping strategies. And then, of course, our expected outcomes: remains free from injury, makes informed decision about treatment. And that's important because just like in my situation, they told me, they said, Miss Locklear, you could wait a year or so, but you are going to have this surgery. And I'm like, well, if I've got to have it, why wait? And so I decided to go ahead and have it done this summer, and I'm glad that I did, because as I get older, it's just like my doctor told me. He said, you'll never have cataracts again. He said, now you may have to come in about 5 years, and we may have to clean your implants. He said, because they can get cloudy and dirty. He said, but it won't be, you'll never have a true cataract again. Thank you.